Hi friends, I am Dr. Venkatesh. I'm a consultant neonatologist. I am discussing about a neonate who was referred to us with the diagnosis of term small for gestational age baby hypoxic respiratory failure meconium aspiration syndrome. He was born full term small for gestational age. His APGAR score was 7 and 8 at 1 and 5 minutes respectively. He did not require any active resuscitation. He was looking dusky. Despite increment in the FiO2, his oxygenation did not improve, remained at 70. He was then transported to neonatal intensive care unit. He was ventilated with a pressure of 20 by 5, rate of 40 and FiO2 almost 100. The chest X-ray was performed, unremarkable except mild dilatation of the right atrium. So the diagnosis was made persistent pulmonary hypertension, thinking that this baby might require nitric oxide, inhaled nitric oxide. He was transported to our unit. When we examined the baby was looking dusky but not in distress. So clinically we thought might not be due to meconium aspiration syndrome, the hypoxia. The blood gas was normal except PaO2 around 40. Then the bedside echocardiography was performed. It showed the dilated right atrium, atrial septal defect, ventricular septal defect, and patent ductus arteriosus. The right ventricle was hypoplastic. There was no movement of tricuspid valve. It was atretic. The color Doppler demonstrated the blue jet entering from the right atrium to the left atrium. Then blood entered from left atrium to left ventricle and from left ventricle to right ventricle through ventricular septal defect. And forward flow from right ventricle was good. So at this moment the diagnosis was made: tricuspid atresia, hypoplastic right ventricle, atrial septal defect right to left shunt, ventricular septal defect left to right shunt, patent ductus arteriosus bidirectional, then the counseling was done with the parents. They were informed about the cardiac condition. Meanwhile, this baby also was started on prostaglandin. Parents were counseled about the steps involved in the surgery, need for cardiac transplantation, the later part. The parents, they required some time for the discussion. Meanwhile, baby started to improve with oxygenation. The prostaglandin was weaned and stopped completely. It also had hypotension in between, so we had to start the baby on dopamine, which was tapered and stopped. Gradually, this baby was extubated to CPAP, then to the room air. At the moment, baby is on room air, saturating 89, 90, preductal and postductal saturations. He is on full feeds, accepting Palada feeds also. So we are waiting for the parents' decision. The cardiac team, including the cardiologists and the cardiac surgeons, are involved. The parents also have been counseled by the team. This is a story. The importance of this is, in a neonate, when we have a baby with hypoxic respiratory failure, dusky looking, not much respiratory distress, though there was evidence of meconium aspiration syndrome, think of something beyond. So here, it was diagnosed as meconium aspiration syndrome causing PPHN, but if you look at the whole story, it turned out to be a cyanotic heart disease, tricuspid atresia, which is duct dependent. This may not require any procedure at the moment because there is a big VSD, but needs to be monitored periodically by the cardiac team, and the parents need to be counseled periodically. Thank you so much for the patient hearing.